Good evening, Endo Summit Live, and we are here with our 7th webinar in the 2025 season. Tonight, we're talking all about neuropelviology with two amazing international doctors. Joining us from Mexico is Dr. Ana Sierra. Dr. Sierra, can you introduce yourself, please?
Hi, nice to meet you all. I'm Dr. Ana Sierra. I'm an endometriosis surgeon with neuropelviology studies with my practice in Mexico City. And we also have a little center here in Tijuana.
Oh, exciting. And also joining us from Latin America and Brazil is Dr. Henrique Abrao. Dr. Abrao, can you introduce yourself?
Thank you very much for the introduction, Salim. It's an honor to be here with you and with Ana, who's a great friend of mine. I'm Dr. Henrique Abrao. I'm from Brazil. I am also an endometriosis surgeon. And I did last year a 1-year fellowship with Professor Mark Possover, who is the founder of Neuropelveology. And I've been studying all of the nerve implications in pain and in pelvic dysfunction ever since. And it's a big, big honor to be here with you.
Excellent. We are excited. So let's get into it. What is neuropelviology?
Ana, please.
Okay, neuropelviology, it's a science that Dr. Possover, it's not that he really invented, but he noticed it. Because the nerves that are in the pelvis do manifest some ways in the pain that when you understand them, you can help a lot of patients. So I think it was born as a necessity to give answers to people with pain.
Excellent. And so what is the training like to work in neuropelviology? Could anyone that has an understanding of the nerves understand this?
I think it's a complex question because as it's a new kind of specialty, it's a new part of medicine, and we are speaking new. We are speaking around 20 years. In medicine, 20 years is nothing, but 20 years is very, very recent, is new. And but it has already some knowledge that it's affirming the science. But nowadays, who's been teaching a lot of neuropelviology is Professor Possover. He has his teaching class and everything, but there are some other ways to learn. So you need to find some way to get into neuropelviology, coming either from neurosurgery, from complex pelvic surgery, even from urology, from gynecology,
Orthopedic surgeons.
Orthopedic surgeons, any specialty that it's available, that's ready to go into the pelvis and to explore the nerves outside the spinal cord. And I think that's the start to neuropelviology. But to become a neuropelviologist is nowadays with us. So it's for us to get, to train, to understand. And the main place, the main strategy to learn is to listen to our patients' pain and to our patients' symptoms. That's, I think, it's the best way to learn.
The International Society of Neuropelviology offers courses. You can take the ISON Level 1 course, which is online, and you can also take ISON Level 2 workshop, which is going to Zurich to learn from Dr. Mark Possover himself. So you can start learning in a more structured way about the way that the pain manifests on our patient's pelvis. So you can find the ways, because as we have learned, pain is not just a pathology. Pain is information that travels through the nerves. So that's the way that, well, that's the hookup, or that's the quote from Dr. Possover that got me into this, because it offers a different way to explore the pain, not as the enemy, but as a clue. So that was amazing for me.
Perfect.
Excellent. So, that's a good transition when we talk about pain being information. How might the evaluation and what I say, the intake of patients be different for you looking through a neuropelviologist lens than just, I don't mean just, but just somebody who does endometriosis excision? How is that evaluation and those diagnostic experiences different?
First of all, we not only think that pain is caused by endometriosis. We know that there are a lot of causes that can cause pain. There are a lot of different manifestations or different pathologies that make another things in our patient's body. It's not only endometriosis in some of the cases. So that's why we can offer a more rounded or more focused treatment in order to find the diagnosis for our patients.
And I think, as Anna said, it's the diagnosis is key. I mean, we have a lot of endometriosis. That's right. We need to listen and we need to care about our patient's pain, but not everything is endometriosis. We have some other different diagnoses, and I don't know how about you in Mexico, Anna, but here in Brazil, there is something going on that everything is becoming endometriosis, and
Yeah.
we are missing some diagnoses that are not. So we have some different diagnoses of the chronic pelvic pain, and there are lots of studies from many other things that can cause similar symptoms, and we are just throwing everything else away with this easy diagnosis that it's becoming endometriosis. That is not an easy diagnosis at all, but it needs to be taken seriously.
We
Of
have
course.
that in the US. And I am a physical therapist, so I look through a different lens. And when you try to talk to a patient about that, it could be, say, a connective tissue disorder, or it could be actually driven by the bladder itself, or there could be all these other causes of pain. They focus on the endometriosis, and patients have been minimized so much that if I try to say something different, they get very aggressive with me. So it's interesting to hear that you're hearing that from other areas of the world.
That's definitely our case here in Brazil. I have a case of a patient that I saw today in the clinic that is typically a case that it's driven by the bladder, a chronic pelvic pain, very, very typical, and this kind of pain that may be similar to endometriosis. And this patient did a lot of MRIs, did several MRIs and ultrasounds looking for endometriosis. And the same time that we take to get the diagnosis of endometriosis, it's somehow in this case of this patient is a 27-year-old patient that took 6 to 7 years to go out from the trying to find some endometriosis to justify the pain, and this pain in the inferior bowel that goes to the back, and it's somehow so associated with the men's bleeding, but has some differences. And this different diagnosis, we did a long clinical examination and everything, and we came to the bladder as the main cause.
Also, vascular entrapments. When we talk about a pain that is cyclical in the pelvis, the first thing we think about is endometriosis, but also vascular entrapments can be with a cyclical pain. And they also can
Definitely.
come with heavy menstrual bleeding. And they also can come with a lot of pain in the legs and a lot of symptoms that can be similar to endometriosis. So we have cases in our center of patients that have gone with Lupron and all these treatments for really suppressing estrogen, and the cause of their pain was a nutcracker syndrome. So I think we have to really study the patient before we start the treatment. As we have already said, the diagnosis is the key if we want to treat the pain.
So Dr. Abrao, how would you study the patient? Walk me through the steps.
So neuropelveology, as Jan, I think Professor Kosova, I have a huge, I'm hugely grateful for all of his knowledge and everything he taught me. And he established a line of care to the patient that it's very interesting. I think it works very well. He brilliantly gives the patient a pre-consultation formulary. So we have in advance the history of the patient first to organize the consultation. And as the patient comes with this history, with this linearity of pain and associated symptoms, the patient herself can already go to her own symptoms and better understand it. So we come to the consultation. It's not a 15 minutes consultation at all. We do like a 30 minutes anamnesis, and then we go to the physical examination. That is more like a neurological examination with dermatomes, with analysis of reflexes at Achilles reflex, patellar reflex. We do a lot of interesting things that how come the reflex on my knee has something to do with some entrapment in the pudendal nerve. And there may be some correlations, and it's very interesting how pain and all of those technical neurological informations can give us answers that are hidden from someone that it's not taught to look at it. And then after all of this, we go back to the diagnosis and to propose a cause of this diagnosis. For example, radiculopathy, that is a pathology on the root of the nerve, and it's maybe caused, for example, to a piriformis syndrome. That's an example. And then we go back to this, and if we need, we go for the image, and usually it helps us, image and electroneuromiography and other things that will help us to the diagnosis for us to propose a treatment.
Well, you asked the question, so I'm going to ask it to you. How does the knee reflex, how is it impacted by the pudendal nerve? First of all, you have to define pudendal nerve for our team out there.
Okay. Yeah, actually the knee reflex itself, it doesn't have a direct relation with the pudendal nerve, but with the roots that go to the pudendal nerve, they're also responsible for the posterior tibial innervation. So there is a relation with this, for example, patients with overactive bladder. One of the lines of treatments are electrodes in the leg, in the posterior tibial nerve, that will help us to modulate, to do the neuromodulation of this nerve that goes to the bladder, to the same that goes to the spinal cord, to the same sacral nerve roots as the pudendal nerve. So the pudendal nerve is basically a nerve that goes out from the roots S2, S3, and S4. So in the sacrum, the second, third, and fourth nerve root that goes out from the sacrum, they form also the sciatic nerve, but those three will form the pudendal nerve that will go into the pelvis and then go out to the pelvis through the alco canal, and then they will go to the perineum and to the outer side of the pelvis, to the pelvic floor, into the rectum, into the vagina, and into the clitoris. And they will give lots of different information. That's why Professor Pothover says always that the vagina is a key point to understanding pelvic nerves, because it's very, very rich in terms of information on the upper third, on the middle third, or the lower third of the vagina. What is the information that it brings to us? And some of this is because also the pudendal nerve.
So you're both, I assume, also OBGYN. How much of that did you learn in school? Because in pelvic PT, you don't learn that good exam to be able to, I actually could identify each nerve in each third of the vagina. You don't learn that till very advanced courses. Who's talked to you about this in OBGYN training? No one?
No, actually, I learned about the muscles of the pelvis and how to examine them because I have a physical therapist who were kind enough to explain to me how the bulbocavernosus feel, how did a lot of them, the rectal, all of the muscles that are in the anal sphincter. So they were kind enough to teach me, and that's how I've encouraged or added this to my physical exam. And now I can say that when there's a pelvis that has a contracture, I can send them with a diagnosis, because physical therapist is like one of the keystones in our practice.
Right. We talk about it all the time. The patient that comes in with the script that says treat pudendal nerve, you have to then do a complete exam, because to most local OBGYNs, that's it. They think the whole thing is pudendal. They don't realize how many nerves innervate the pelvis. So that's my soapbox. It's really difficult. So I have a question. Dr. Sierra, you specialize very much in the connection of the bladder to the nerves. Can you talk a little bit about that type of interaction, the bladder and the pelvic nerves?
Okay, everything begins in the nucleus poncinus in your brain, and then the signal will be sent. But we have like three systems fighting for the control of your bladder. We have two autonomic and one that is very somatic that you can control. So these autonomic are like, I already see this example, I like two brothers wrestling, the sympathetic versus the parasympathetic. And they are wrestling each other because they do opposite things. The sympathetic system is going to relax the muscle of your bladder and is going to close your internal sphincter. And your parasympathetic is going to compress your bladder in order to begin the voiding of the bladder, and is going to open the internal sphincter. And by the end of this reflex, you have the voluntary phase, when you open the external sphincter because of your pudendal nerve. So the sympathetic it comes from your lumbar region. It's come from the sympathetic, which is the superior hypogastric plexus, and it divides into two nerves, both of the hypogastric nerves. And the sacral nerve roots have an anterior branch, which are the parasympathetic nerves. And they come together with the hypogastric nerve, becoming into one, the inferior hypogastric plexus. So this very important plexus that gives an autonomic reflex to the bladder, to your pelvic floor, and to your rectum. All of this is in the back side of your uterus. We have two ligaments, which are not really ligaments, but are like foldings into the peritoneum, and it's called uterosacral ligaments. We have information that the two lower thirds of your uterosacral ligaments are the inferior hypogastric plexus. So if there's anything compressing this, aka endometriosis or a lot of pathologies, you can have a lot of symptoms. So for example, if you lose your sympathetic system, these two brothers which are wrestling, it's like when you were very mischievous and when you were arm wrestling with someone and you stop wrestling, the other guy is going to fall, right? So if you cut the sympathetic, the parasympathetic is going to be really excited, and your bladder is going to be really excited, and the muscle is not going to know who is going to listen to. So you may have an hyperactive bladder. So it depends on the symptoms is going to be the cause. And we have to study really well. That's why we do urodynamic testing in some of our patients. We have a lot of information with this urodynamic testing, actually, because one of our neurourologists has been very keen and very thorough with these studies in order to understand how the bladder behaves in cases, because when you compress inferior hypogastric plexus, you can really injure sympathetic or parasympathetic nerves. And also we know that one little spot of endometriosis can be or have an inflammatory response of 3 centimeters in diameter around it. So it doesn't have to compress the nerve, it just has to irritate the nerve, and our patients are going to have a lot of symptoms.
Very well done. Better than that's the whole course. We have that's it. We could all go home. I don't have to run the rest of the conference. So how do you approach that? I would say, I work a lot with the American Neurological Association on teaching the connection that people should recognize bladder pain comes with endometriosis.
Yep.
So once you see that connection, what do you do about it? What are the
First, I think that the first thing to do really well is the anamnesis, as Enrique was saying. Like, it's not only about pain in the bladder. It's okay, do you pee in the night? How many times you have to pee in the day? Do you know every restroom in the perimeter whenever you walk? You have to, when in the place that you work, do they tell you that you have a really tiny bladder, or why do you have to stand up and go to the bathroom every hour? Those are the questions that patients are like really used to because, oh, I have a tiny bladder. I have to pee every hour. Yeah, that's not normal. So whenever we have to begin like by giving them like a journal in order for them to tell us how are they peeing. So that's the first red flag to see about these symptoms and how are they feeling when they are emptying their bladder. Because when you stand into the WC, the toilet, and you don't feel that the stream is going out, that'll be the first red flag. Also, the feeling that you didn't empty your bladder fully, that's another red flag. Some of our patients have told me that they have to make a fist and push their bladder in order to empty it. But that's normal, that's me. No, that's not normal. And you don't have to push to empty your bladder also. You don't have to make about the external muscles. Your detrusor muscle should be enough to empty your bladder. So all of these symptoms come before making a urodynamic study because we have to check about the red flags into the anamnesis. And that's only the first half of our consultation, no, as Enrique was saying.
You know what's interesting? When we were abroad, we had to explain to the male doctors that women can push on their bladders to make themselves go. A lot of them didn't understand because there's a little anatomy difference.
Okay.
That is such an important question. I was developing a questionnaire, and somebody said, "What are the three questions that you ask?" And the first two questions I ask are, is your bladder happy?
You make your
And
bladder gladder?
yeah, make your bladder gladder. And then my other question that I ask is constipation, bloating, and diarrhea. I don't
Yes.
even mention the period when I'm evaluating for endometriosis. I like forget half the time to ask people how their cycles are. What about Dr. Abrao, what about fecal incontinence? How does or constipation and bloating, how do the nerves play a role in that? And Anna did a really good job. So you're like the spotlight is on you.
Now, Anna did so much as a good job that it's now the job is easy for me. She explained the same thing, and it's the physiology behind the bowel is not that different from the physiology with the bladder. We are thinking about the same three systems, the two sympathetic and parasympathetic, the two brothers that are wrestling. Anna did a perfect idea of those systems, and it's really interesting to see how it's really like a balance. When you have the sympathetic, that is the continence, against the parasympathetic, that is the evacuation or the release of the bladder, the peeing, and it's exactly a balance. It's exactly when one is stimulated, the other is down, and when it goes like this all the time. And we have our part, our somatic part, and we use this term somatic to say in a very very, I can say that to teach, we can say that somatic is somehow what we control, okay, and autonomic is we don't have the control of it. And the somatic is the external sphincter that make us control the evacuation the same way as the bladder. So the bloating, if we think about the bloating, and we talk a lot about this when we say about endobelly, the size of the intestines, they are much more relevant than the size of the bladder in terms of the whole abdomen. And this overreaction of the sympathetic nerve system, we are talking again about the continence, so about not being able to evacuate. And when we talk about this, we talk about a lot of constipation, and we talk about a lot of gases going on. And we can talk, and if we go further on this, we can talk about bacterial, hyperbacterial infection with SIBO. And there are lots of things that can accumulate on that. And if we go back to the anatomy, we have all of the kickings of the intestine, of the sigmoid and the rectum. And it's anatomically, depending on the anatomic, in the anatomy of the patient, we have also this factor being able to put in the anatomical part is it's really physical. We have a lot of round corners, and if the round corners are not round, they are very strict. The gas and the feces won't pass. So it all starts with the same idea that Anna just explained, with the sympathetic over expressed, impeding the parasympathetic to work, impeding us to be able to evacuate. And this goes on and goes on and goes on with all of this chain reaction that I just told. And when this other patient that has this balance between the parasympathetic and sympathetic, this is very common in endometriosis in patients that say, doctor, it's very common for me to have 1 week I have constipation, the other I have diarrhea, or during between periods I have constipation, during periods absolute diarrhea. I don't understand why is that. It's this lack of control of balancing. And if we go back also to the pelvic nerves and understanding these pelvic nerves, to the part we can control, and we can control until the second point, but we can modulate, and this has influence to the sympathetic and parasympathetic, the external muscles and the pelvic floor muscles. And this is where we can understand a way to treat and understand a way to downregulate the sympathetic, and we can help our continence, and we can help our evacuation system.
Excellent. So very good. Now you brought it up. So how do the nerve, I mean, I can put the pieces together, but maybe we can help everybody else. But I see SIBO in probably 60 to 80% of the people that I treat with the disease. I don't treat simple cases. I only treat complex cases. What is the interaction of the nerves to the perpetuation of SIBO?
This comes to a big question: who comes first, the egg or the chicken? So that is a very important question, and whoever can answer this will help us understand way better. But I think it's a big snowball. If we have SIBO, it's basically the hyperbacterial infection on the small bowel. And when we talk about SIBO, we talk about overdilation of the bowel because of gases, because this bacteria, the way the bacteria work, they will get the fecal product, and they will turn this into gas. That's the big consequence on a hyperinfection in the intestines, and they may turn into diarrhea or may not. This is not absolutely necessary to have diarrhea and SIBO in the same time. But a big bloating and gas, this is something we need to have SIBO. And we can think if the sympathetic nerves, and we think about endometriosis, we usually start thinking on the sympathetic nerves. The sympathetic nerves are expressed basically with the inferior hypogastric plexus, and it's where we have most of the early cases of endometriosis. It's It's not proven that it starts there, but we all see that there's a lot of endometriosis there. And when we have endometriosis in the inferior hypogastric plexus, even this slight endometriosis, even in peritoneal cases, as Anna said, 3 centimeters radial, we have overreaction of those nerves. And this is something I have sometimes a difficulty to explain to the patients. What is a nerve damage and what is a nerve irritation? A non-neurogenic nerve problem. And this is the irritation of the sympathetic that will slow down the intestines, that will create this constipation case that can be a case to generate SIBO. Or if there is a SIBO and the intestines, they are bloating, and the intestines are the cause of the irritation of the sympathetic nerve system. So it may be one to come first, it may be the other one to come first, but we have this snowball and one gets the other worse.
Yeah, and with SIBO, you have the concept of what does the microbiome do, right?
Mm.
And then we once had a very interesting live with John DeLumba, who would make the argument that the teeny tiny adhesions that the fascia forms are a huge part of the way of keeping that bacterial overgrowth in the gut. That's up on our YouTube. That one is also very fascinating. Boy, we're gonna expand on all of this at the Endometriosis Summit. Don't worry.
Perfect.
You mentioned it before, Dr. Sierra. What is a vascular compression?
Okay, about the congestive venous, or whenever there's something vascular that is compressing the nerves, we have to think about various causes, because there are malformations, or that the way that your venous system doesn't behave the way it should be, because the way that it's anatomically different. But also there are connective tissues, like problems or diseases that can cause that these blood vessels move, like, for example, an Ehlers-Danlos loss or something, that they do not stay where they're supposed to be because of these connective tissue problems, and they can cause a nerve entrapment also, and they can cause pain. But basically, when you have a venous congestive problem, it's like whenever there's like in cartoons, when you have the Wile E. Coyote or something like that, and it starts compressing the hose, and you can see how the pressure starts building up behind it. So it's the same thing when there is, like, for example, in adenomyosis patients, then the uterus, instead of being anteroverted, because of the weight of the uterus, it comes retroverted. So the blood flow cannot come from the venous system upwards. And we start having these really big veins because they cannot go upwards with the flow. And it starts creating new pathways. And these abnormal pathways can also cause nerve compression and can also be traduced as pain. That will be like the most common causes, but we also have these malformations. For example, in Nutcracker syndrome, that we have an artery, a mesenteric artery, compressing the renal vein, and all of this pressure is going to build up into the gonadal vein that goes into the ovary. So the symptoms of our patients is cyclic pain in the left ovary, and sometimes it can come with hematuria. So that's why patients are being treated like they have endometriosis in the bladder. And we have had 2 cases so far of patients coming with Diagnostic treatments or Lupron treatments for a lot of years, and they don't even have endometriosis. So yeah, and also May Turner's, which is also a malformation, or whenever there's an artery compressing the vein, so the flow cannot come into the iliac vein. And we have to help, or that's why we have a vascular surgeon in hand that understands these things and how they cause pain.
Guess what? We have a full hour with Brooke Spencer, who is like the leading vascular treatment of venous nerve disorders
That's
at the
amazing.
summit. I want to see you too. So what her intention is to come to the summit and to learn the pelvic pain and endometriosis side instead of just the blood side. So I have
Okay.
you have to go to like dinner or lunch with her because you
That'll be
too,
amazing.
and she's in Colorado, so like not very far from coming down to see you in Mexico. She's excellent speaker.
Amazing.
And we've been working with one of her patients over on Instagram who actually had was told it's endometriosis, it's your bladder, and it was nutcracker syndrome.
It does happen because sometimes it's easier to think about horses than zebras. But we have a lot of zebras in the endometriosis community and, well, endometriosis in the chronic pelvic pain community. So we have to think about them sometimes when the treatment is not working.
Do you see nutcracker syndrome often missed in women?
So far, it's twice that I've seen, but because I work with a vascular surgeon, we have this training that we do all of our patients. We check the diameter of the blood vessels in the uterus whenever we do the workup. And we do a Valsalva maneuver, which is push, and we can see if the blood flow comes inwards and backwards. So this reflux can also be like a clue that there's something wrong with the veins. And we also try to get to the ovarian vein in both sides so we can measure them. That's part of the workup that we do, like in all of our patients.
Very interesting. And Enrique, do you see vascular compressions playing a role in leg pain?
Same here, actually. I was listening to Anna, and I was seeing my routine. I was visualizing my routine because on Saturday I did a case with the vascular surgeon. Actually, we didn't do anything by laparoscopy or anything like this. We diagnosed a patient that my team has operated this patient 3 years ago, superficial endometriosis. And the patient got better, but not that much, not as much as we expected. She came back to me now as a neuropelviologist. I look at her in a completely different way. And this patient, she had a nutcracker with a May Turner.
Oh my God.
And the obstruction was 80% in the internal in the common iliac on the left vein. And I have a brilliant image that the flow, it's going back, and it's easier for the blood flow to go up to the left side, to the right side, from the right side, than from the place it would go. So we put the contrast in the vein and it goes all the way, and it has a lot of alternative paths. It's crazy. I will share with you this video because it's something, it's the perfect explanation. But just to tell, it explains us, and it's a catamenial pain. We can and we will have this pain associated with the menstrual cycle because of hormones, first of all, because of the cyclical the cyclical way that the hormones they put the month and the patient, but also to the blood flow in the uterus. So more blood flow in the uterus closer to the menstruation, more congest will be those veins. And we have this relation with the blood, with the menstrual cycle, that causes this confusion with endometriosis most of the times in cases of vascular compression. And what about the legs? There are some problems with varicose veins that may be the superior gluteal, or maybe some other vein that it goes closer to the sacral nerve roots. And as I was telling you in the beginning of our Zoom, the same sacral nerve roots that go to the pudendal nerve, that goes to the uterus, that goes to the pelvis, they go to the legs. So if we talk about sciatic nerve, it goes from L5, the last lumbar nerve root, S1 and S2. S1 and S2 are the sacral nerve roots, and S2 has a very interesting relation with the superior gluteal vein, that it's usually between the nerve and the bone, but sometimes is in a anatomical variation that compresses the nerve between the vein and the bone. So in terms of cases that, as Anna said, that this vein is way bigger than it should be, it can press, initially generating an irritation of this nerve that goes until the leg and goes to the back side of the leg, from the back of the leg until the calf. And it has some worsening in the menstrual cycle, but it has one big difference. It gets worse until the day the patient starts bleeding. And in the day the patient starts bleeding, it goes down. And that's very interesting for us to be able to see. If when we go back to the common gynecology, we learn nowadays, 2025, that everything that is catamenial, we should look to endometriosis. And it's good for us to look at this, but we need to take care not to miss other diagnoses. That's something it's important to memorize. Not to take out endometriosis in front of us. No, endometriosis is really, really important. But there are some other some other diagnosis that comes during the menstrual cycle or worsens during the menstrual cycle, the men's bleeding.
Excellent. So both of you work in areas where imaging is a little more advanced than it is in the United States. So readily accessible to you each are more highly specialized MRIs, but also the ultrasounds where the majority know how to do the pelvic mapping. How does these advanced ability to diagnose or mostly diagnose endometriosis with good imaging affect what you can rule in and rule out? Because in the US, I don't know how many doctors will listen. It gets worse as you're getting your period. Oh, but when you get your period, the pain is better. And it's more of a listening than and something they can see in imaging. How does that affect, ruling in and ruling out nerve dysfunction versus endometriosis?
I think
She
good
logged
images.
off. My question was so crazy. She logged off.
No, it's not crazy. I think imaging does help us a lot, and having a really close by radiologist does a lot of difference. Beginning with nerve compressions, because we do the physical exam, and sometimes we do some nerve blockages in order to confirm our diagnosis. But sometimes we cannot do this, and we have to reach out to our radiologist to take a look and see if there's something compressing in the trigger points that we are finding, for example, in our pelvic floor. So whenever there's this feedback and our radiologist can say, okay, you were right, there's like a branch of the nerve that has like something that is compressing into it. There's like a vein, there's a muscle, there's tissue. There was something, for example, the slings that they sometimes leave when they perform a surgery or a tacker. Whenever you find this, it's like really amazing that you can confirm your diagnosis with your radiologist. So I think it helps us improve the quality of our diagnosis. I don't know if your question was going that way, but I think
excellent.
okay.
I think if you let me add something, I think image is very important. I think in Brazil, at least, image is crucial for our diagnosis. We have this this concept here. We are used to having image to confirm, but I think that's something very interesting when we talk about nerves. We are talking about, and I love this way the Professor Posova explains nerves. It's like the electrical cables of a home. We cannot see electricity passing by. We can see the lights turning on and off. We can see the switch working or not working. And this is the information. Nerves are very, very tricky when we think about image, because we cannot see the image of the electricity passing by. We cannot see if the nerve is working or not. Of course, if the nerve doesn't work for a long time and it has a big atrophy, it's something different. But That's something very interesting. So, of course, for endometriosis, it's lesion. Images can see. We are very used to this. I don't survive without a good ultrasound and a good MRI. But for nerves, it's very important for us to have a suspicion in the clinical examination, in the evaluation at the clinics. And then we go to the image to confirm our calls. So, I'm thinking about vascular entrapment. I go to a specific MRI protocol that I developed with my image guys, with the team that does the radiology team that does MRIs here. Because for example, vascular entrapment, for us to diagnose a dilated vein, we cannot be laid down for some time. We need to be standing up. And how can we do an image in the MRI standing up? So we need to develop this theory, but thinking about our diagnosis. If I have a diagnosis of vascular entrapment and put the patient laying upside down for 1 hour, it will never diagnose because the vein will close, will shrink. So we need to think what is our diagnosis and confirm it with the image.
Yes, excellent. And so I want to just circle back to something that you mentioned in the beginning, which is orthopedists and nerve and neuropelviology type work. I know that this sounds maybe a little silly. I didn't realize until I took some of the courses. I think of the nerves and the compression and the vascular compressions really always going through surgery, through the laparoscope, and we're in the belly, we're along the nerves. When I saw the orthopedists do that kind of work, they actually go in through the hip and they're working on the other side, so not in the belly. It was absolutely fascinating. Have you had a chance to work with a lot of the orthopedists doing this kind of work?
We did it like one time in a patient that allow us to do both laparoscopic and arthroscopy, but it wasn't like for a special kind of treatment, just to see how the nerve was coming outside, because the patient was a doctor and wanted to see his nerves. But basically, this is not something that I had a lot of experience like from the cadaver lab that you saw.
Right.
It's not like an everyday practice that we perform.
It was for our physical therapists out there watching who treat hip pain and hip pain and hip pain in the person with pelvic pain and endometriosis. It was a completely different approach to look at how the nerves, not that are directly coming out of the sacrum, but how the fascia interacts not in the belly side, but really on the spine and the glute side. And to see those tiny little fascial compressions of the superior gluteal nerve and how much it affected the patient. It was really mind blowing for our PTs out there. So as we end this evening, we are going to open up questions in the Q&A here on Zoom. We have most of our followers out on Facebook tonight, but the Endometriosis Summit 2025 is coming up on March 28th through the 30th in Orlando, Florida. Apparently the two of you are joining us. We have a full 2-hour panel, 2 hours. You know, that's like an eighth of the Endometriosis Summit is devoted to neuropelviology, and Dr. Spencer's full hour workshop, which is sort of an offshoot since she's doing pelvic venous disorders. What are you looking forward to the most about the Endometriosis Summit?
I think
You're on.
I think last time I learned so much from the patients and from other colleagues. So I think this summit gives you the opportunity and to see it on the other side and to talk with the patients about how does the pain affect their everyday lives. And you can hear so many testimonies and how do they approach the way that life is changing because of the pain. No? Some of them were talking about like having to share your body with an alien or something like that. No, and it really helped me like improve the quality of my diagnosis and to really try to help them like to be in their shoes. Not exactly, but I'm really looking forward to this neuropelviology because I think the people need to know more about neuropelviology, that it's not just something that it's becoming hip or something that is going to be like an hour course that you can learn, that we can really assess a patient, and if done right, we can give some answers. I think neuropelviology for me was that, to have some answers, because patients with chronic pelvic pain are usually like uh, light bust, like they do not listen, or they are not listened to, because of they have the same complaint over and over. So they, I don't know, as you don't know how to treat them, you really don't treat them. So I think it was amazing for me to find neuropelviology and understand the pain. That's one of the things.
It's an analyzation system. It's not a surgical technique. That's what I think, like the last year of learning about neuropelviology is that it's an approach. It's a different approach to the body. It's not a technique. That's what I hope everybody's take-home message will be. Yeah. And Henrique, you're joining us at the Endometriosis Summit for the first time. What are
Definitely.
you looking forward to the most?
I'm really looking forward for this event. Last year, I joined the Endometriosis Summit Brazil, and it was it was really different, the format of it, but it was a very nice start for beginning for me in this doctor-patient discussion and this exchange in the same level. I think we are not going to a place that patients are learning from us. We are both learning, and as Anna said brilliantly, and from someone that has already been to the Endometriosis Summit previously, I really think the best way to learn is to listen. The only way to learn is to listen, and first to listen to the patients that have symptoms, and to those are the patients, the people that can teach me and teach us how to improve our treatment, how to improve our consultation, how to improve our approach to the pain and to this terrible, in terms of symptom, but excellent information that pain represents. And first to develop, I think we started talking about the history of neuropelviology, and 20 years, it's already something. It's a long history for us, but in terms of medicine, it's too short. And it's a huge opportunity for us to write history with each other, for us to learn and to improve and to go further. I really don't believe that those chronic pelvic pains are untreatable. I believe we still don't know fully, we still don't fully understand the treatment. And I think this is a very good opportunity for us to improve and to reach ideas and to reach other ways of treating. And treatment, I'm far away from talking about surgery. I'm talking a lot about a different approach, and starting with a very strong influence of physiotherapy, of biofeedback, of lifestyle changes. And we start in this part of treatment, and we go further ahead to improving the patient's quality of life. And we do it together.
Absolutely. Excellent points. So we have a very good question. And one, I do a lot of work in nerve compression of the ilioinguinal nerve. So this is one of my favorite questions. What about vaginal and anal itching? Could that be a symptom of the nerves, and why?
Yes, they can.
I know. It's one of my favorites to discuss. Because everybody just wants yeast infection medication. They don't realize that that's a symptom of nerve dysfunction.
Usually when you have a lot of treatments for something that doesn't work, so you treat 1, 2, 3, 4 times and doesn't work, it may be a red flag for us, or a yellow flag, or maybe red flag for us to see this may be not the right way to go. And the interesting thing about nerve is that the symptom is not where the lesion is. The symptom is not where the problem is. And itching, if you understand exactly where is itching, and if you understand neuroanatomy, you can go directly to the point. So we can have the vaginal part, we can go to the pudendal nerve, we can go to the genitofemoral nerve, we can go to several different nerves and several different parts, and the association of it gives us the right way. So
I think I would ask first, which are the other symptoms? Because those are the ones who are going to give us a clue. Because you have this anal itching and the problems in your vagina, but if whenever you're sitting, does it increase? Whenever you're laying down, does it increase? Or do you have any dysfunctions of your bladder? Do you have any dysfunctions? Do you have barely, you have problem emptying your rectum? There's a lot of other things that have to be going on, because I think that we're both thinking about sacral radiculopathy, but it can express with a lot of nerves. So it's like a little part of the clues that we have to analyze in order to give a full diagnosis. But
No
yes.
pun intended. Maybe pun intended. So
Yes,
what
no.
I think is really important, and what I describe is, if you sat on your foot for a really long time, what would happen? You would get pins and needles in your foot, and the brain is going to usually, you felt pins and needles before, so it knows that sensation. But the itching, whether it's in the vagina or it's anal itching, is oftentimes that's your brain's interpretation of what the nerve is doing. Now, all the other questions, that's part of a full and comprehensive exam. And also plenty of patients who assume vaginal itching must be yeast. I tell patients, don't ever take a yeast cream until you've swabbed 100% for it. So there is one last question, and it's on, and now we're getting all the questions. Don't worry, I'll stay on even after they left to answer the question. So there's a question about vagus nerve and POTS, and I'm going to leave that for the endometriosis summit, because we
Okay.
have a full hour on the vagus nerve, and we have
Oh,
a
well.
full hour on venous disorders, which venous disorders aren't exactly POTS, but she's going to cover POTS. And the reason why we don't have a full hour on POTS is because there's a lecturer who has it, and she was supposed to come, but she's too ill to do it. So I promised it to her next year. So now we're going to do venous disorders as a whole. So if you're looking for an answer on vagus nerves and neurostimulators and POTS, then that's a good person you should be attending either in person in Orlando, Florida, or virtually from anywhere in the world, www.theendometriosissummit.com. Okay, we're wrapping up. And I apparently will be in touch with more details that the two of you have forgotten. Any last thoughts this season?
Thank you so much for this opportunity, and I see we can see each other in March.
Excellent. So I tell as we head out, my favorite Ana Sierra story is that I was speaking at AAGL, and I'm describing the nerves, and I said, and these are the nerves that go to the bladder, but I am not a neuropelviologist. And just as I said it, the doors flung open, and in walked Dr. Ana Sierra, and she waved. I said, oh, the neuropelviologist has arrived. So I am very excited that the neuropelviologist will be arriving at the endometriosis summit, because you guys are sleuths and you have a lot of information and different different practitioners and everything that you can gather all that information from. So I'll see you all soon. Thank you for this evening. I'm gonna,
Thank you so much.
you guys can go. I'm
Thank you
gonna
very
stay on
much.
in
Okay.
case other people have questions.
Thank you so much.
Yeah.
Goodbye,
Thank you.
Sally.
I know it's tough with
Thank
the
you.
time.
See you in March.
Bye bye.
Take care.
Bye.
All right, let me stop the live stream. And I will stop the recording. Okay,